Здравствуйте, мои коллеги. Я Уриф Islam. My presentation about antimicrobial resistance. It is part from my master thesis work. It is called the microbiological studies on some carbaminomases producing gram-negative bacteria pathogens. Content it will be introduction, aim and objectives, material and methods, and results, and in the final conclusion. Beta-lactam antibiotic, it is a certain type of antibiotic, consists of several groups. La première, cephalosporins, carbapenems, monobactam. All of these compounds or all of these classes share beta-lactam ring, but differ in sulfur group. Penicillin and cephalosporin contain sulfur groups, whereas carbapenem don't contain sulfur group. Instead, they contain carbon group. The action of this group of antibiotics, they cause cell wall lysis or break down the bacteriological layer in the cell wall, causing death of the bacteria. Why we choose carbapenem? Carbapenem possesses the broadest spectrum of activity and the greatest defense against gram-positive and gram-negative bacteria. As a result, they last line or antibiotic of last resort. Members of carbapenems include ertapenem, imipenem, meropenem, and doripenem. Now, we know the classes of antibiotic, but we need how the emergence of carbapenem resistance in gram-negative bacteria. There are several mechanisms of resistance. For example, enzymatic inactivation carbapenemation by binding protein, whereas that is the target site of antibiotics, or decrease outer membrane permeability. They don't allow these carbapenems to enter into the bacterial cell in the final flux of the antibiotic. When antibiotic enters the cell wall, they go out again. Beta-lactamases. Beta-lactamases are certain types of enzymes produced by bacteria cause breakdown of the beta-lactam ring. There are several types of beta-lactamases, like penicillinases. The inactivated penicillin, so methicillin, was developed to combat this type of enzymes. Cephalosporinases cause inactivation of cephalosporin and aminopenicillin. And extended spectrum beta-lactamases cause inactivation of all beta-lactam except carbapenem. They inhibited by clavulanic acid. And in the last, imipenem or carbapenemases, they are certain types: imipenem, veropenem, calypsylinase resistant carbapenems. All of these carbapenems have the ability to hydrolyze all beta-lactams, even carbapenem. So they called carbapenemases. Different type of carbapenemases and certain type of bacteria. The question now, why carbapenemases producing bacteria is a public health emergency? First of all, significantly limits treatment options for life-threatening infection. The resistant mechanism is now on a transposon and resistance is highly transmissible. Rapid detection and effective infection control measures are essential to control spread, cause infections associated with high mortality rates. In most areas, this organism appears to be infrequently identified. So our aim and objectives was isolation of gram-negative bacteria from different clinical samples and screening of carbapenemases resistance among them, After that, we made identification of the recovered imivenom-resistant isolate and testing their susceptibility to different antimicrobial agents, and the detection of carbaminomases production among imivenom-resistant. And in the final, we make microbiological and biochemical characterization of the detected carbaminomases. How work was done? First of all, we made isolation of gram-negative bacteria from different clinical samples, from urine, from blood samples, from sputum, and other samples. After that, we make identification and culture on Maconche agar plate, where it is a selective media for gram-negative bacteria. And after that, we made preliminary screening of imivenom resistance using agar dilution method, containing the breakpoint of carbapenem 4 microgram per milli. And identification of the recovered imivenom resistant isolate by standard biochemical tests and make confirmation of the identity by multi-TOF mass spectroscopy. In multi-TOF mass spectroscopy, we make culture of bacteria and put them in the instrument, and a laser of beam was run detecting the bacteria, and the chemical structure was identified by mass spectrophotometer. And after that, we would make susceptibility tests using about 18 antibiotic discs by disc diffusion method. And after that, we made determination of MIC values of imivenom using agar dilution method. MIC mean minimum inhibitory concentration. It is the lowest concentration which inhibit bacteria. So if we can compare between different antibiotics, we use the MIC. The lower the MIC, the best antibiotic or the potent antibiotic. And after that, we made detection of carbaminomases production among imivenom-resistant isolate by modified Hodge test. All of this test will be explained later in the result. Okay, modified Hodge test and the spectrophotometric detection of carbaminomases for further confirmation. And our results were about 1,000 samples were isolated from sputum, from stool, from blood, from purine, and we culture them on Maconche agar, where about 580 of gram-negative bacteria were isolated. Among them, it was found that about 104 of these isolates were imivenom resistant, including Klebsiella pneumoniae, Proteus mirabilis, and Pseudomonas aeruginosa. All of these isolates were imivenom or carbapenem resistant. And after we made susceptibility tests, it was the result where most of the isolates showed resistance to cephalosporins and ampicillin antibiotic, whereas the least resistant were against tigecycline antibiotic and chloramphenicol. This image showed the results of susceptibility tests, where red color indicate resistant strain, green color indicate sensitive strain, and yellow color indicate intermediate strain. As shown in this figure is the antibiogram typing of Escherichia coli. The antibiogram typing of Klebsiella pneumoniae. This cluster typing showed a relationship between the resistant strain and their source of isolation. And this antibiogram of Proteus mirabilis. All of these bacteria are resistant bacteria. gram-negative and highly resistant bacteria. They called multi-resistant bacteria. And finally, the antibiogram of Pseudomonas aeruginosa. Determination of the minimum inhibitor concentration or MIC of imipenem among the tested imipenem resistant isolates showed that only about 9 isolates showed lower resistance to imipenem with concentration 2 and 4 and 8 microgram per milligram. But the rest of the isolate were highly resistant, even reached to 250 microgram per milli of imipenem concentration. It is a preliminary screening test for carbapenemase detection. It is called the modified Hodge test. The idea of this test was the test was performed by the following method. We make culture of Escherichia coli, which was a wild type of Escherichia coli. It was sensitive to imipenem, and as shown in the middle, we put a disc of imipenem antibiotic, and after that, the tested isolates where we want to see their sensitivity and resistance were directed from the disc to the edge of the plate. As we shown in this figure, there are about 4 tested isolates. The positive carbapenemase strains showed hatch or the circle or the inhibition zone is turned out or hatched. As shown in this figure, the strain now coded 580 and 104. They are sensitive or they are carbapenemase producer, whereas the other 2 strains are not carbapenemase producer. Using this test, we detected about 52 of the isolates were imipenem resistance. The percentage was about 50%. Escherichia coli was predominant. Escherichia coli, Klebsiella pneumoniae, Proteus mirabilis, and Enterobacter aeruginosus and Pseudomonas aeruginosa. And with confirmation of this test, we made what is called spectrophotometric analysis for the carbapenemase activity. We make incubation, we make extraction of this enzyme and incubate it with the bacteria, and we incubate it with the imipenem antibiotic and show the effect. The strains that not produce carbapenemases, there is no decrease in the spectrophotometric mass of the imipenem. There is no decrease because the imipenem was not breaked by the bacteria or by the enzyme. Whereas positive isolates that produce carbapenemases break down the carbapenem antibiotic and show decrease in the activity. By this test, we found that about out of the 52 isolates, there were about 35 were positive for carbapenemase activity by UV spectrophotometry, and the results was put in this table. As shown at time 0, the absorbance of the imipenem was high, and after about 600 seconds, it was lowered. Finally, we made what is so-called EDTA double disc diffusion test. This test was specific for certain type of carbapenemases called metallo-beta-lactamases. metallo because they contain in their structure zinc component. We in the middle we put a disc of EDTA, and the tested isolate were cultured, and we put imipenem discs where positive isolates that produce metallo-beta-lactamases show it in the right image. They were hatched towards the EDTA because EDTA make complexation with zinc zinc metal that present in the metallo-beta-lactamases, whereas negative isolates, as shown in the left, there were no hatches. What was our conclusion? Our conclusion was the incidence of carbapenem resistance among gram-negative bacterial isolates is alarming problem among hospital settings, especially because of their high rate of resistance to cephalosporin and all penicillins and quinolone. The use of tigecycline should be the last resort for treatment of infections caused by highly resistant gram-negative bacteria. Also, this study displayed a good sensitivity of imipenem-resistant isolate to chloramphenicol. This should shift our focus to re-examine older antibiotics that had largely been banished because of their toxic side effects or developing newer derivatives to abolish their side effects. Also, our results confirmed that the previous studies that modified Hodge test lack high sensitivity and specificity compared to spectrophotometric method for detection of carbaphenemases, and it is necessary to depend on spectrophotometric detection of carbaphenemases. And our final conclusion is thinking about nanoparticles to abolish the resistance of these isolates towards carbapenem. And thank you for your attention. Спасибо за внимание.
So, mostly respectful professor and dear colleague, I'm Amirat, PhD student in genetics. I will go for oncogenes in breast cancer and possible treatment options with my colleague, Surgeon Dr. Mikhail. First of all, our agenda is, as you see, I will talk about the first 5 points, and my colleague will continue the remaining part. So at first, we talk about introduction. So breast cancer is a heterogeneous disease which required update on scientific research to offer patients the best possible and personalized treatment. Modern surgical treatment of breast cancer is recently been reviewed, and it's clearly a field of continuous change and improvement. The change in treatment strategy is a challenge given that prognosis is already acceptable. The collaboration between specialties across different countries and different knowledge background is needed to exchange experience and improve international guidelines. That's why surgeon and genetic specialists work together for this article. After that, we'll talk about epidemiology. So, breast cancer is the first cancer to affect women in most countries of the world, followed by lung cancer and colorectal cancer. The statistics showed that the incidence of breast cancer is higher in developed countries like USA, Europe, and Australia than the less developed countries like African and Asian countries. However, the mortality rate is much higher in underdeveloped countries due to the lack of diagnosis and treatment means. Breast cancer can be divided into two types. Sporadic breast cancer, which is the most common breast cancer resulting from accumulation of occurred and uncorrected mutation in somatic cell genes, and hereditary breast cancer, which result from the loss of heterozygosity at the level of tumor suppressor genes. such as BRCA1 and 2 in classic hereditary breast cancer or P53 in Li-Fraumeni syndrome. The alteration of genes is due to the action of risk factors that are subdivided into two categories: non-genetics factors such as aging, late menopause and pregnancy, hormonotherapy, as well as the modern lifestyle, including smoking, alcohol usage, and fast food. The genetics factors are due to the Mendelian transmission of cancer predisposition genes such as BRCA1 and 2 and P53. Breast cancer is caused by the alteration of different types of genes. The main genes are the proto-oncogenes, which after transformation become oncogenes and confer the cancerous phenotype. These oncogenes encode for the growth factor EGF, growth factor receptor like ERBB2, or transcription factors such as MYC gene. Tumor suppressor genes like BRCA1 and 2, which are the most implicated in hereditary breast cancer, P53, which is always mutated in all cancer and can be associated to hereditary breast cancer in the case of Li-Fraumeni syndrome. We found also that RB protein is involved in hereditary breast cancer because it regulates BRCA1 and 2. The steroid receptors such as ER alpha are also involved. In addition, several other genes are involved in breast cancer as apoptosis genes, invasion and cell adhesion genes, and oncogenesis genes, but with a lower penetrance. Now I let Dr. Mikhail continue the rest.
Thanks a million, Dr. Amin. Because we are working in the behalf of the human being and the behalf of our patient, so we must go secondly to know what are the clinical features of breast cancer. We must remind that the breast cancer develop clinical symptoms rather late at advanced tumor stages. So typical signs may include changes in breast size and or shape, symmetry or asymmetry, palpable mass, typical or atypical, skin changes, whatever they are, redness, edema, and pitting of the hair follicles, nipple changes, inversion of nipple changes, or blood changed discharge, axillary lymphadenopathy, and also in advanced stages, ulceration. Here you can see how we can manage in the patient the palpable mass, how it looks like, also enlarged axillary lymph nodes and skin retraction, either nipple retraction or nipple discharge, pseudorange, inflammation, or carcinoma in Courvoisier. All the times we are looking for diagnostic scheme or algorithm in order to manage our patients without forgetting the triple assessment for this patient, but we must take in account the age of the patient, as my colleague mentioned before. So if the patient age was lower than 30 years old, we must go for clinical assessment, probability of the malignancy. If low, so re-examine within 3 to 10 days, and after that reassure and follow up. And if it's high suspicious mass, so we must go for ultrasound and fine needle aspiration. What we must see there, if we will see cystic lesion, so just with clear fluid to assure and follow up. And if we will find residual mass with blood fluid, take core needle biopsy. And if we will take this core needle biopsy, it might be benign or malignant, and I'll talk after that about it. And if it will be solid lesion, suspicious mass, so we must go for core needle biopsy. And likely penile mass, we must treat as needed and observe. If there is growth, so we must go for core needle biopsy. And sometimes, if difficult to reach the lesion, we must excise it. And if the patient is higher than 30 years old, we must firstly do scanning with mammography. And all the world now are going for the scanning program with mammography to all the women above 30 years old. If there is suspicious of mass, we must go for corneal biopsy, and if difficult to reach, excise it. If it's benign, follow up. If it's malignant, just imaging with MRI and do lab diagnostic with receptor testing tumor markers, and also staging with lymph node biopsy. Possible treatment options, not just surgery. Possible treatment options can be also radio and chemotherapy, and also other targeted therapy. We mustn't forget the role of multidisciplinary team. So the surgeon, the oncologist, the pathologist, and all other colleagues which are going with us to choose the needed choice for every special patient. In early stages of the disease, we can say breast conserving therapy, so lumpectomy followed by radiation therapy. If in intraoperative lymph node is seen, so we must do evaluation by sentinel lymph node biopsy and also axillary dissection. Also the adjuvant systemic therapy, hormones, and targeted biologic therapy in all of this. Here you can see the breast conserving therapy, and also locally advanced disease, we can go for some choices of non-adjuvant systemic therapy and followed adjuvant therapy. And if advanced metastatic disease, systemic treatment followed by palliative surgery. If gestational breast cancer, remember that it's not the type of surgery, stop it, but you can go for anything after the second or third trimester. If non-invasive carcinoma, you can see it in this slide, either ductal carcinoma in situ or lobular carcinoma, you will go for breast conserving therapy or lifelong surveillance and chemo radiation. I will be very happy to be with you with my colleague. Thanks a million. If there are any questions remaining to genetics or remaining to surgery, we will be very happy to answer it. If not right now, we will be very happy to answer it via mail. Thanks.
Thank you.
К следующему докладчику слово предоставляется аспиранту Института биохимической технологии и нанотехнологии Российского университета Дружбы народов РИС Марко Георгий Халим.
Да, всем здравствуйте.
Здравствуйте.
Good afternoon, my dear professors, my dear colleagues. My topic for today is about modern biomedical applications of graphene, and this topic will include the following points. First of all, introduction, and the second point will be drug gene delivery and cancer therapy, biosensing and bioimaging depending on graphene, graphene-based antibacterial materials, graphene-based scaffold for cell culture. Next point, recent products on the market, and the conclusion in the last step. Graphene is a novel two-dimensional nanomaterial. It possesses several exceptional physical and chemical properties that lead to many potential applications. These properties include electronic, optical, thermal, and mechanical properties. Graphene was produced by two scientists, Andrei Geim and Konstantin Novoselov, in 2004, who were awarded for this discovery Nobel Prize in Physics using graphenium graphite. That is a special, highly ordered pyrolytic style graphite with flake sizes ranging over a centimeter. It's arranged in a hexagonal lattice. The resulting graphene has earned the title of a wonder material being both the thinnest and the strongest material known. With the rapid development of synthesis and functionalization approaches, graphene and its related derivatives have shown outstanding potentials in many fields, such as nanoelectronics, energy technology, sensors, and catalysts. The structure of graphene gives it outstanding electrical and thermal conductivity properties, making it ideal for use in electronics, solar cells, batteries, and high-speed transistors. Equally, it has great potential as a component in composite materials and protective coatings used in many industrial applications, including aircraft, buildings, and even spacecraft. The intensive research on the bio-applications of graphene and its derivatives is due to many fascinating properties, such as a high specific surface area, exceptional electronic conductivity, thermal conductivity, mechanical strength of graphene, and intrinsic biocompatibility, low cost, scalable production, and facile biological chemical functionalization. There are many trials had been already proved the value of using graphene oxide, which is one of graphene derivatives, as a drug delivery system. In a study, water-soluble chitosan derivative was used as reducing and stabilizing agents to perform the green reduction of graphene oxide, which then were blended with alginate hydrogel beads. And this formula showed a great drug loading efficacy for small molecule fluorescein sodium, sustainable drug release of 71.6% in 150 hours at physiological pH, while quick release in an acidic medium. Progressive steps in genomics and gene therapy introduce novel solutions to many incurable. However, the difficulty in designing effective and safe delivery system or vectors for the appropriate genetic cargo keeps these advances inapplicable. So graphene oxide and the other nanoparticles family showed a good adsorption ability towards double-stranded DNA, which make them excellent vectors for genetic cargo. One of graphene family members is graphene nanomesh that was used for the purpose of gene delivery. Graphene nanomesh has a great adsorption affinity because of its enlarged surface area and therefore more active sites. The structural features and simple chemical preparing and alternation of graphene oxide give captivating opportunities for loading and delivery of an assortment of molecules from chemical drugs, genes, and photosensitizers, and beyond for cancer and other disease treatment. And in one study, a doxorubicin-loaded bigylated nanographene oxide was developed for the anti-tumor effect in vitro and in vivo by blending of photothermal and chemotherapies. The experiment resulted in the combined chemophotothermal therapy exhibited synergetic effect that leads to better anti-cancer effect than chemotherapy or photothermal therapy alone, resulting in higher therapeutic efficacy. Another bioapplication of graphene is because of the fabulous electrochemical behavior of it. It's a promising electrode material in electroanalysis. Many electrochemical sensors based on graphene and its composites for bioanalysis and environmental investigation have been developed. Graphene-based enzyme biosensors, graphene-based electrochemical DNA biosensors, and graphene-based electrochemical sensors for heavy metal ions are examples of biosensing applications. The size of graphene sheet or graphene oxide sheet in particular was reported to have an important influence on the antibacterial activity of graphene oxide, an effect that was relied on the type of assay used for toxicity measurement. Graphene oxide-based surface coatings revealed higher antimicrobial activity for smaller graphene oxide sheet size. For cell suspensions, graphene oxide sheet area affected bacterial development by a cell entrapment mechanism. Under these circumstances, the antimicrobial activity of graphene oxide increased with increasing sheet area. In any case, cell entrapment was found to be reversible, showing that the clear impact of graphene oxide doesn't include bacterial inactivation and maybe can be described as bacteriostatic. Graphene-based scaffolds are utilizing for tissue engineering of heart, bone, cartilage, nerve, skin, and liver due to their beneficial properties, especially their antibacterial action. As we mentioned before, graphene membranes may be promising candidates for their application in visual regenerative medication. And here in this slide, we can see that several companies have launched graphene enhanced textiles, inks, and coatings incorporated into personal protective gear, such like face masks, gloves, etc., and applications like air filters and room cleansers have been developed. And graphene mask is one of the available graphene products on the market. It's composed of 3 layers, 2 layers of cotton, sandwiching a proprietary graphene textile blend, which is the middle layer that may increase protection against the COVID-19, even this virus, and other dangerous airborne viruses. Biomedical applications of graphene and its derivatives, especially graphene oxide, are numerous and very promising solutions for many incurable ailments. In the future, there will be more attention to these nanoscale materials in order to get novel compositions having higher bioavailability with lesser toxicity and more selectivity. Yet there are challenges such like a thorough and profound understanding of graphene cell interactions, especially the cellular uptake mechanism. And this challenge and many others are the matter of researchers to find out solutions for smarter nanomaterials. Thank you for attention, and any questions, please. I'm carefully listening.
Good afternoon, dear professors, dear colleagues. Permit me to introduce you to our today's talk about using antibiotics on various surgeries with my dear colleague, Dr. Mikhail Shahada. We'll be following this agenda. I will be doing the first half presentation, and Dr. Mikhail will do the remaining. A major health problem in hospitals nowhere is the increasing of antibiotic resistance in patients. In general surgical field, the main or the major factors are prescription of antibiotics for viral infections, the frequent use of broad-spectrum antibiotics, and irrespective of duration and the cause of usage. The selection of antibiotics for usage in pre-operative period depends on multiple factors, which are the type of infection, the patient allergies, the type of applied surgery. The most commonly used antibiotic in surgery is the first-generation cephalosporins and gentamicin. In the case of anaerobic infection, commonly used metronidazole or tinidazole. In the case of staphylococcal susceptibility, commonly used antibiotic is the flucloxacillin or vancomycin. We found a very interesting clinical trial of Turmozoglu and al., which assure our principles. The study was based on 176 patients with various surgical infections, and the results were as follows. The study applied that the broad-spectrum antibiotics are the most commonly used in surgical practice. And now is the turn of my colleague, Dr. Mikhail.
Thank you, Dr. Ibrahim. It's my pleasure to be with you the second time today in this great conference. So I talk just about the types of surgery according to microorganism. We are classifying the types of surgery according to microorganism: clean surgery, clean contaminated, and contaminated surgery. If we will go for health skin incised for clean surgery, we will not recommend antibiotics, either not the clinicians or the guidelines. If prosthesis, we can recommend antibiotics. If clean contaminated, either respiratory, alimentary, genitourinary tract infections, we can recommend antibiotic. Contaminated surgery as microscopic soiling of operative field, also as example in peritonitis, strongly recommended antibiotics. In all types of surgery, just we measure now the microorganisms and some selective antibiotics for each type. Thoracic surgery, for example, we can find in swabs Staphylococcus aureus or Coagulus negative staphylococci, so we can use cefazolin, cefuroxime, sodium, and so. In gastrointestinal surgery and also in gynecological surgery, we can find enteric gram negative bacteria, anaerobes, enterococci, also group B streptococci, and other anaerobes. We can also use cefoxitin, cefotoxan, cefazolin, ampicillin, and sulbactam. Orthopedic surgery, mainly, we can find Staphylococcus aureus and Coagulase negative staphylococci, so we can use cefazolin and cefuroxime sodium and vancomycin. Also, in vascular surgery, we can find Staphylococcus aureus, Coagulase negative staphylococci, and enteric gram negative bacilli, so we can use cefazolin and vancomycin. So cefazolin is remaining one from the most important antibiotics in surgeries. Impact of antibiotic misusage, we have two major factors. It's the high treatment cost sometimes and the increasing of mortality rate. So I was very happy to be with you, and in conclusion, the optimization and respect of guidelines internationally and the usage of antibiotic needed to be by priority on every healthcare center, every specialized hospital. The classification, as we mentioned, clean surgery, clean contaminated and contaminated, respectively provided the improvement of usage of antibiotics and the development of many initiatives, the replacement of antibiotics by another ones can lead to favorable results. Thanks a million, and those are our references. If you have any question, you can ask us now, or you can just send to us via mail. Thanks a million, dear professor. It's my pleasure to be with you today with the third step. So the third talk to me today will be just in the topic of my research. It will be about antibiotics in inguinal hernioplasty. So my name is Mikhail Shahata Fakhri. I'm assistant lecturer of operative surgery and clinical anatomy and PhD student also on general laparoscopic surgeon. My agenda will be introduction, some necessary question about this topic, and after that we'll go for conclusion. You may hear those words one day. They will schedule the operation as soon as operating room is available. So what is surgical operation? For those who don't know what is surgical operation, it's a medical procedure involving incision with an instrument performed to repair damage or arrest damage in the living body. And what are the types of surgical operations? There are a lot of classifications for the types of surgical operation. Now I go for the type according to the urgency of the operation. We will go for urgent operation, which be a must or life-threatening operation, emergent operation, which must be within 6 to 12 hours, and elective or scheduled operation when we give the patient time to come with his investigations for us in the inpatient clinic. For any operation, we must consider pre-operative management, operative management, and post-operative management. Pre-operative management, for sure, it's before the operation, including all the investigations we will order from the patient and also the clinical assessment of the patient. Operative management will be just the set in the operation theater and also the anesthesiologist recommendation and the anesthesia set. And post-operative management, including follow-up for the patient. Specifically, we will talk about those points in quick. What is inguinal hernioplasty, herniotomy, herniorrhaphy? What are the options of operation all over the world? What are the complications of this operation? And when we must use antibiotics, pre-operatively, during the operation, or post-operatively? Is there any difference in using antibiotics during this operation according to the urgency of the operation? Also, is there any difference between using antibiotics according to the international guidelines and the clinical practice? Okay. Please, colleague, who mute yourself. Also, what about the randomized clinical trials done in answering about this question? So, first of all, inguinal hernioplasty. We must know that about 20 million patients and more all over the world every year are going for inguinal hernia repair. The many different approaches and treatment indications, also with a significant array of techniques for inguinal hernia repair, warrant to standardize care, minimize complication, and improve the results. So, what is the difference between herniorrhaphy, herniotomy, and hernioplasty? Herniorrhaphy is the classic one, the oldest type of the operation of hernia repair. It involves a surgeon making a long incision directly over the hernia, then using surgical tools to open the cut enough to access it. And herniotomy, an operation for the relief of a reducible hernia by cutting through the neck of the sac, while hernioplasty with the usage of mesh repair. In hernioplasty, instead of stitching the muscle opening shut, we cover it with a flat, sterile mesh, usually made of flexible plastics such as polypropylene or animal tissue. This operation had a lot of options all over the world. Classical option, it's open repair, traditional one, laparoscopic repair, modern technique, and in some countries, robotic hernia repair. There is no single standard for inguinal hernioplasty, and the choice of this method is based on the experience of the surgeon, technical capabilities, and the desires of the patient sometimes. The most commonly used methods for autoplasty or Schuldeis repair, and among allohernioplasty, Liechtenstein repair, it's traditional and the golden standard all over the world in open hernia repair. Also, laparoscopic methods, the most commonly TAP and TIP, so transabdominal peritoneal hernioplasty and total extraperitoneal hernioplasty. And this is what we have this long introduction. What are the complications of inguinal hernia repair? Complications after inguinal hernia repair are relatively common. The incidence is higher after emergency repair and recurrent hernia repairs compared with elective surgery. With the transition to tension-free repair, hernia recurrence is less frequent, while other complications such as post-herniorrhaphy, neuralgia have become more prominent nowadays. Complications that occur in the perioperative period include wound seroma, hematoma, urinary retention, bladder injury, and surgical incisional site infection. While complications that occur later on, so post-operatively, following hernia repair, include persistent groin pain and post-herniorrhaphy neuralgia, testicular complication, deep incisional and mesh infection, recurrent hernia also, and mesh migration with erosion. So the possibility of infection preoperatively and postoperatively still very high. Urgent and emergency procedures are associated with higher complication rates compared with elective repairs, as the surgical site infection and mesh infection are from the complication of hernia repair, so we need to use antibiotics. But when we must use antibiotics, shall we use them preoperatively? Shall we use them during the operation or postoperatively? And if we would like to use them, shall we use just a single dose and when and or treatment course? When we must use antibiotics, there are a lot of clinical trials all over the world which assure the prophylactic antibiotics in open mesh repair like the laparoscopic inguinal hernia repair. When we will talk about the prophylactic antibiotics in open mesh repair of inguinal hernia, we will see that all over the world they are not using in clean surgery any antibiotic, but the recommendation and guidelines go through that we must use in mesh repair according to not non-mesh repair or tension-free repair. Even though the reported incidence of wound infection varies to 9% and sometimes till 15%, as more and more surgeries are done as day case surgeries, many of these infections are often recognized first in the outpatient setup or outpatient clinic after discharging the patient from the hospital. The most common organism isolated was Staphylococcus aureus, which forms a part of normal skin flora. It is a well-known fact that increased preoperative hospital stay increased the risk of colonization with resistant bacteria. Cefazolin, in a lot of literature, is the antibiotic of choice and also in a lot of hospitals all over the world. How we can use them? 1 gram of cefazolin must be given intravenously at the time of induction of anesthesia, so in the operative period. Also, prophylaxis prescribing patterns in laparoscopic inguinal hernia repair give us the ability that where evidence suggests antibiotic prophylaxis not necessary, may and many surgeons still use them routinely. Single dose of antibiotics during the operation induction. The use of antibiotic prophylaxis during hernia repairs with mesh may be more important than in non-mesh repairs because of the consequences of graft infection. Surveys conducted among surgeons have reported that about half of them use antimicrobial prophylaxis for hernia repair, whatever the operation is clean contaminated or contaminated. So, is there any difference in using antibiotics during this operation according to the urgency of the operation? For sure, yes. If prophylaxis antibiotics has not a great role in some literature in low risk rate patient, but it has a great role in emergency complicated inguinal hernia repair. So in case of Amyand's hernia, for example, the hernia in which appendix or inflamed appendix, a part of it, is essentially used pre-operatively, during operation, and post-operatively also as course of treatment. A reducible hernia as a cause of intestinal obstruction needs also to have follow-up and give the patient a course of treatment, which will include also antibiotics. Complicated hernias which need urgent repair without mesh also are in need. So, is there any difference between using antibiotics according to international guidelines and the clinical practice? The Association of Surgeons of Great Britain, also the European Hernia Society guidelines with the National Nosocomial Infection Surveillance assuring a lot of things from them, the system index which identifies the following risk factors for surgical site infection. Surgical site with a wound classification of either contaminated or dirty infected must take antibiotic. Also an operation lasting more than 2 hours or more than 75% of the time allocated for the operation must go for antibiotics. The patient's American Society for Anesthesiologists score of more than 3 must also go for antibiotics. A long duration of the operation and drainage are listed as procedure-related factors, and also comorbidities such as diabetes mellitus, rheumatoid arthritis, obesity are also included among the risk factors. Surgeons still using prophylaxis antibiotics as a single dose during the induction for elective surgery. Also, they still use treatment course of antibiotic for 7 days during the emergency complicated hernias. And also, when will we go for reviews of studies according to literature, we will find a lot of them. I choose just one from the study, prospective and randomized trial, preferably double-blind one, which are of the greatest value. And 12 such studies have been conducted over the past 15 years. 3 of them demonstrated the efficacy of prophylaxis in the prevention of surgical site infection, while 9 of them recommended against its routine use. This is a trial study in which you will see the sample size and the antibiotic we are using, or those people who used in Spain, Turkey, Netherlands, also Philippines, Greek, India, and Egypt, Japan, and the percentage of infection which were related post-operatively. This is the explanation for what I just said. In conclusion, using antibiotics in the practice of inguinal hernia repair still essential to predict the surgical site infection. The single dose of antibiotics as induction is preferable in practice despite some literature studies. Using antibiotics in complicated inguinal hernia or in those patients with high risk for mesh infection and surgical site infection as a treatment course of 7 days reduces the post-operative complication. Thanks a million. Don't hesitate to ask me any further question. If you would like to ask by mail, I will be very ready.